This program is a presentation of UCTV for educational and non-commercial use only.
Welcome to the Mini Medical School. Today's topic is low back pain. We're going to have two speakers this evening. I'll be the first speaker. My name is Praveen Mamneni. I'm with the Neurosurgery Department here at UCSF. The second speaker is my partner, Dean Chow, who will be discussing some of the more surgical aspects of this topic. I'll try to focus on the non-surgical aspects of the topic and the causes of low back pain, which I think is a problem which is affecting more and more people as the population continues to age and as the population lives into their 80s and 90s. This is a more prevalent problem. So I think it's a topic that could be of benefit if all of us know what are the basic drivers of why people are afflicted with low back pain. I want to acknowledge my fellow Bijal Amin, who helped me to put this talk together. And I'll share with you some of the ideas on causes, conservative treatment, and some of the few surgical interventions now for low back pain. I do have some disclosures. I'm not currently a consultant for anybody, but in the past I have been. I do get a royalty from DePuy Spine and Quality Medical Publishers for some of my hardware and textbook work. So the primary causes of back pain, I try to differentiate why patients have these causes when they come to my clinic. I think the most common thing that I see in my clinic is muscular spasm. And one of the other common things that I see is facet joint arthritis. The younger patients tend to come with herniated discs, often with nerve compression, with sciatica, which is pain coming down the leg. Degenerative disc disease is a pattern which I see in patients typically between the age of 50 to 70 years old who lose the hydration of the water content of their discs and the disc spaces collapse. Spondylolisthesis means slippage of the spine. It's graded on a 1 to 4 scale. The vast majority of patients have a grade 1, which is a less than 25% slippage of the spine. So we'll talk about that. Stenosis means that you have arthritis growing on top of your nerves, and the nerves don't have enough space in the spinal canal, and patients often have back and leg pain with that. Scoliosis is something which over the last 20 years I've seen more and more in the population age over 60. Typically when a lot of people think of scoliosis, they think of teenagers. Sometimes for those of you who went to the school perhaps in the 60s, saw a lot of teenagers wearing braces, some of them quite uncomfortable looking braces. They came up to their jawline and down all the way across their back, trying to stop their scoliosis from progressing. But this is a problem which now we see in a lot of people who are age over 60, and it's not the same pattern of scoliosis as teenagers get. And this is a lumbar degenerative scoliosis that people get over the age of 60 and is becoming quite prevalent. And then the last thing which we'll touch on is spinal trauma. And this is another issue which I think we see more and more of because patients have osteoporosis and they tend to get osteoporotic compression fractures in their lumbar spine, which can be quite painful. And so we'll touch on each of these major causes of back pain. These are probably the 7 or 8 top causes of back pain that I see in my clinic. And basically this list here will cover almost all the patients that I see in my clinic with this kind of a problem. Let's start with muscle spasm. Probably the most common thing that people tell me when they have back pain is, quote unquote, my back gave out on me. I had to lie down for several days. I couldn't move. It just hurt so badly. And what is it that's happening when your back gives out on you is typically what's happening is that you're having a big muscle spasm. You've either pulled the muscles tight or the muscles are going into spasm to try to protect the disc underneath or the nerve underneath the muscles, and it can be so excruciatingly painful and can be quite sudden, and because of the suddenness and the excruciating pain, it limits the range of motion and people basically go lie down. This often accompanies other degenerative processes. You have to have a reason for the muscle spasm. It could be just a muscle pull, but it can also be a trigger from the nerve underneath or the joint underneath, which is causing the muscle to be irritated. The treatment for this is not really surgical. It's conservative treatment. And things that can be done include physical therapy with stretches, muscle strengthening, the use of muscle relaxants. Some patients like hot packs. I've seen alternatively some patients like cold packs. There's no real science to it. The hot pack works fine. The cold pack works fine. Some patients like to strengthen their core muscles by doing things like aquatherapy. But I think this is the primary driver that you see in most patients who say that they have sudden back pain. What they're complaining of, what their back gives out on them is a muscle spasm. Muscle spasms can come and go. They can come with increasing intensity and frequency if there's a big underlying problem. So if you get frequent muscle spasms and you're frequently incapacitated by it, then often your doctor may want to look further and see what's going on by doing something like an MRI. But the average patient who gets a muscle spasm while, say, moving their furniture around, the vast majority of these cases, the muscle spasm will go away with some bed rest and with some hot packs and maybe a little muscle relaxant. The vast majority do not have muscle spasms that will cause them to seek surgical intervention. So a very common complaint that patients have is the muscle spasm. Now, sometimes patients have muscle spasm because they have arthritis underlying the muscles in their back. So if we think of the back in layers, so you look at it from the back side, there's skin, then there's a layer of muscle, then underneath the layer of muscle there's bone, and these bones move. And these bones move by the joints, and they move by the joints called the facet joints, which are in the back side of the spine. So this is looking at it from the back, and this is a facet joint here, and here's another facet joint here. And so these joints will allow the spine to flex and extend and to rotate. And so on the front side of the spine, the disc moves, and on the back side of the spine, these facet joints move. And what can happen in your 60s is essentially these joints start to get very, very arthritic. And as they get arthritic, they lose their nice, smooth synovial lining, which is the lining that allows those joints to slide back and forth. And as you get bone spurs forming in those joints, every time you bend and twist in a certain way, that joint can be aggravated and cause pain. Now, how do you assess if someone has facet joint mediated pain? Well, there's some things that you can do on your examination of the patient. You can load the facet by having the patient lean back and then off to the side. So that kind of a maneuver, back and off to the side, the back maneuver puts weight on the facet joints, and off to the side puts weight on one single facet joint. And so that's the kind of maneuver where I have them in the clinic lean back into their side and ask the patients if they tell me that that reproduces their typical pain, that's an indicator that could be coming from their facet joint. In addition to that, if I take my finger and I palpate that joint, and some of these joints can be very, very arthritic and knobby, and you can actually feel them under the skin as a big bony knob. And if you put pressure on them, they can be very tender. And those facet joints can cause a lot of arthritic pain. The pain is typically just off midline, a little bit off to the side, midline being these spinous processes in the center, and this is usually about a ½ inch to an inch off to the side. So those joints, if they're arthritic and tender, can cause muscle spasm overlying. If you put pressure on the joint in the wrong way and then it pulls on the overlying muscle, you can have a muscle spasm. So if you get frequent muscle spasms, one of the reasons why you might get it is because you're getting arthritis in these kinds of joints. And this is the kind of thing that we look for on X-ray and sometimes on CT scan and MRI scan if the X-ray is not satisfactory to find it. Now, if you have this problem in your facet joints, what should you do about it? Other than trying the typical non-steroidal anti-inflammatory medications, things like aspirin, ibuprofen, those are the typical anti-inflammatories where no matter what part of your joint and your body is inflamed, they'll help you, can also help this kind of pain. If those medications don't help you, then you can move on to a little bit more invasive treatment, such as having an injection of steroid into the joint. And the injection of steroid in the joint, a lot of folks ask me, is this the same kind of steroid that athletes are using? And it's not the same kind of steroid. That is the kind of steroid we put here is a glucocorticoid. It's a powerful anti-inflammatory. It doesn't have the anabolic effects that you think of when you talk about steroids for athletes. And those kinds of steroids typically do not raise the blood sugar. Oral steroids, if you give them sometimes, can raise the blood sugar. That's a problem in diabetics. So most non-insulin dependent diabetics can have these steroid injections into the joint without a problem. These facet joint injections are not the same as epidural steroid injections. So that's another question that I often get in the clinic is, I had an epidural steroid, it didn't help me. You're saying that I need a facet joint injection, but why are we trying to put steroid back in there when it didn't help me? And the reason is because an epidural steroid is put here, and an epidural steroid is primarily for nerve root irritation. A facet joint injection is not put in the center, it's put out here in the joint, and it's specifically for a joint irritation, and so it's a different location that the steroid is placed. And so even patients who have failed epidural steroids, I'll send them for these injections, which I don't do these injections myself, but we have a lot of colleagues here at UCSF, like the pain management doctors and the radiologists, who will do these for us. And now sometimes what happens is you get an injection of steroid into this kind of a joint, and the steroid will wear off and the pain will come back. And then there's an alternative procedure which the pain doctors can do called a radiofrequency ablation, where there's a small sensory nerve root that lives in this joint, and they can burn that nerve root using a radiofrequency probe. And so it's a needle procedure. They put it in there, and then they burn the little nerve root that sits in the joint. And that usually can create about a year of pain relief. Sometimes those nerve roots grow back, and then they have to do it again. So it's only in patients who have failed all of these measures, who have a single level of facet joint problem at one single level in their spine, that I might think of doing surgery for back pain. But the vast majority of patients don't have surgery for this problem. What about lumbar herniated discs? This is another very common problem. Lumbar herniated disc is a problem that affects more of the younger patients. Typically quite active people will come and they'll have usually they can even tell me the incident that they were doing, lifting something heavy, skiing, surfing, whatever it is, and they will basically, from this disc space, squeeze out a little fragment of disc, and it'll hit the nerve root here, and that will usually send back pain with muscle spasm, plus pain down the buttock into the leg, sciatica. And so that can be very excruciatingly painful. Patients often, when it first happens, can be temporarily bedridden from the pain, and they usually come limping into my clinic. And the thing that I look for if they have a lumbar herniated disc and they're complaining of sciatica is, do they have weakness? Did they get a foot drop? A foot drop means that you have such a big lump of disc here that it's compressing the nerve and kinking it so much that the motor function of the nerve is not working. And when you get a foot drop, if you don't restore the motor function of the nerve within 1 to 2 weeks, that foot drop can be permanent. And the problem with the foot drop is if it happens on your right side, which is your driving foot for those of you who drive, then it's really difficult to be hitting the gas pedal and the brake without your foot working, with your ankle not working, because you have to have that function in order to be able to drive. So foot drop, weakness, this is something that I jump on pretty quickly surgically because I don't want that nerve to lose its motor function. Sensory function loss, meaning pain with preserved motor function, patients can still move their ankle up and down and move all their toes. I don't jump on as quickly, and I will try conservative measures. These patients often typically have low back pain with the muscle spasm in addition to having that kind of a problem. So how do we treat the lumbar herniated disc? The vast majority of these cases also are treated without surgery. We try sometimes giving some oral steroid. We may give epidural steroid injection, and that's the injection that comes in more in the central area and goes on top of the nerve roots. Or if we want to target one specific nerve, we can do a selective nerve root sleeve injection where we inject from the outside in and try to capture one specific nerve. And if none of these work and anti-inflammatory medications like ibuprofen don't work, then sometimes we do a microscopic discectomy where basically we come in with a small incision here and then shave that little piece of disc out. One of the questions I often get is, we did a lumbar microscopic discectomy. Now there's a hole here where the disc fragment squeezed through the annulus or the lining of the disc and is pushing on the nerve. What are you going to do to close that hole? I can't close that hole. So that hole is always there. There's 10% chance that even if I clean out the fragment of disc that comes out, that people can squeeze out another fragment through the same hole. And so I usually tell the patients for the first 2 months or 3 months until this area scars over, you don't want to go lifting, bending, twisting. And the hardest people for me to tell not to do that to are the surfers and the skiers who want to go out there immediately and do the same thing over again. So we cannot close the hole. You may reherniate the disc. Once it's out, there's a hole. It scars over time. The scar is never as good as the original annulus of the disc, which keeps more of the nucleus or the soft stuff on the inside. The question was, how do you recognize foot drop? And so,
What is complete numbness of one's foot?
yeah, so if we talk about nerve function, sensory function gives you numbness and pain, and then the motor part of the nerve moves the ankle up and down. This is for the L4-5 disc specifically. So it's the motor part of the nerve that is not functional that gives you the foot drop. The sensory part of the nerve is not functional, you get the pain and the numbness. So what are the indications for a lumbar discectomy? Definitely if you have a foot drop with a big disc, we want to get rid of that problem. Or if you have a herniated disc and you did not respond to conservative measures, then we will typically do a lumbar microdiscectomy. And now these microdiscectomies are being done more and more minimally invasively, and some of the patients go home the same day because the incision is only about a ½ inch big. And most patients, almost all the patients, go home within 24 hours. So this is basically how you do that operation. You look through a microscope. You put a small tube here, expose the disc, and then you take out the little fragment. You do have to take off a little bit of bone to do it in order to get the disc out of there. What about degenerative disc disease? And I think my partner Dean Chow is going to focus more of his time on degenerative disc disease, so I'm not going to focus too much of my time there. But basically what happens in this problem is, with a lifetime of wear and tear, the tall, nice colored discs here, here's a normal looking disc, nice and tall with some gray in it, another nice tall one, some gray in it, this one has some gray, that has some gray. You can see this disc is collapsed. It's not tall like this one. It's collapsed, and there's some of it herniated out the back, and then the bone above and below the disc has changed color, and we think the reason for this is because this disc has lost its shock absorption, and now the bone is absorbing some of the shock. So that's degenerative disc disease, and that is something that patients often have problems sitting, because when they sit, they load all their weight on the bottom disc. And the other thing they have problems with is forward bending to touch their ankles or their toes, because as you bend forward, you bear your weight on this disc and you load this disc, and if it's lost its shock absorption capacity, then you can have degenerative disc disease related to low back pain. So what do you do if you have this problem? Well, I tell patients basically to think of their back as a structural building. The center structure, which is the disc, if they have this problem, is weak. It's not normal. They've lost water in their disc space. The disc is collapsed. So now when they're loading this space, they're putting pressure and causing pain. But there are other struts, if you think of a building, that can bear some of this weight. And one of those other struts is the low back muscles. So if you keep your core muscles strong in your back, and you keep your abdominal core muscles strong, then basically you splint this abnormal disc by bearing the weight on your abdominal musculature and on your back musculature. So the number one thing to do if you have this problem is to have a nice strong core muscle of your abdomen and your back so that you don't bear weight here. And if you're able to do that, and typically this is associated with some weight loss, often the pain from this problem will go away and you do not need further treatment. And I'd say at least more than half the patients I see, I never do anything surgical for this kind of thing. I try to get them to lose weight and strengthen their core, and this gets it better, and we don't have to do a thing. What about spondylolisthesis? Spondylolisthesis is slippage of the vertebra. So if we look at this previous example, the spine is not dislocated or slipped here. It's a nice smooth contour of the vertebral column. In this picture here, you can see that this bone has slipped off of this bone. So if this is L4 and this is L5, there's a slippage anteriorly L4 and L5. And as it slips, you can see the disc usually kind of bulges out the back and can trap this nerve root as it's trying to come through the hole. So this problem is spondylolisthesis, or so-called slipped vertebra, and it can lead to stenosis, meaning pinching of the nerve due to the disc slipping and protruding into the spinal canal. And when we see this problem, what we want to do in our clinic is we want to see, is it a mobile slip disc? And how do you do that? You check a flexion x-ray, so the patient bends forward and you do an x-ray, and you check an extension x-ray, so they bend backward and do an x-ray. And if this is sliding back and forth, translating an extension and sliding forward in flexion, and they have dynamic nerve root compression, then it's considered potentially unstable spondylolisthesis. Spondylolisthesis is graded on a grade of 1 through 4, and this is a grade 1 example. It's a less than 25% slip. When you start getting high-grade spondylolisthesis, where this bone basically falls off the front of this one, then for sure you're going to need surgery. But many of the grade 1 spondylolisthesis, you don't have to do surgery. You can try the same conservative maneuvers that we try for the other things in your spine, like physical therapy, steroid injection to try to alleviate the inflammation of the nerve, and getting your core muscles strong. And it's only if those measures fail and the patient's having mobile and painful nerve root compression and back pain, that they may need a spine fusion. Now, the other issue why people have the spondylolisthesis or slip vertebrae is sometimes they crack their bone here. And this bone that connects the front of the spine to the back of the spine right through in here is called the pars bone. And that bone can crack for a variety of reasons. It can crack for congenital reasons where the bone is thin and narrow, it just never really completely connects. Or patients can have trauma, land on their bottom, say with a hard skiing accident, and they can crack this bone. If this bone is cracked and doesn't heal and this is slipping back and forth, we typically do operate on those patients ultimately because they can't seem to really get pain relief until we secure the broken bone. And that's called an isthmic spondylolisthesis, and some of the data that we have shows that that's one of the most effective ways to treat low back pain if they have a fracture inside their spine. So to get the vertebrae to fuse is not a matter of just putting the hardware in. You need bone graft, and the bone has to heal to the parent bone. So typically what I do is I'll harvest some bone out of the pelvis, the bone marrow, and I'll pack that either inside the facet joint or inside the disc space, so basically these bones will be connected. So it's cracked. Hardware alone will not hold you forever. It'll come loose. You got to heal the bone. So disc replacement is the option for this problem here where you don't have slippage, because we do not have currently facet joint replacement. So if your facet joints are bad, spondylolisthesis means you have a problem in your disc space and a problem in your joints. We can't replace the joints. So the treatment for this is fusion. The treatment for this, where the joints are okay and the disc space is bad, sometimes people will try a disc replacement here. Now, disc replacement is basically an artificial disc which does the function of the parent disc.
What's the success rate with it?
So I have personally not been a big proponent of disc replacement in the lumbar spine. I think if you look at people who do a high volume of these, they'll say that they probably get somewhere around an 80% success rate with them. But the problem is that there's so much of the body's load is sitting on that bottom disc that with some traumatic, things that people do, bending, lifting, twisting, falling, landing on their bottom, some of these disc replacements can sometimes migrate out of position, and it's very difficult to fix them. So I personally haven't really chosen that in most of my patients. I've tended to go with the fusion. Now in the neck, that's a completely different story because you only have 10 pounds of head weight. The lumbar spine hasn't been my favorite operation, though it does have its proponents. So the question there was, I have to repeat the question for the mic, it was asking about disc replacement and when it was appropriate. So the other thing that happens a lot is patients come to clinic and they're wearing a back brace. And they ask me, I feel better in the back brace, and they don't want to take off the back brace, and they say, I can just keep wearing my back brace. Well, the issue is, in the short term, back bracing can help muscle fatigue and can give your muscles a break, but it's like a cast. And if you wear a cast long enough, those of you who've ever broken a limb and wear a cast, when you take the cast off and you look at the muscles of your arm or your leg, the muscles shrink. And why do they shrink? Because you haven't used those muscles. So you wear a cast on your back, which they'll call a back brace, for a long time, months, years, then all the muscles underneath become weak and you become very dependent on the brace. And this is a real problem to try to rebuild those muscles, because as those muscles get weak, then those muscles cause continued problems and will start to spasm at the slightest provocation. So though we use back braces in youngsters for scoliosis, in patients who are over the age of 50, I'm not a proponent of using lumbar back braces for the long term because the muscles become atrophic, weak, and then I have to fight against that with therapy to try to recover them. So question becomes, when should we operate on patients? And Dean will cover some more of this, but I was part of a lumbar guidelines group where we tried to establish when patients should and should not have surgery for low back pain related issues. And so we looked on our first, we'll look back at this as literature from a couple of decades in the English language, and found over 1,000 citations of when people were doing lumbar fusions. And we looked at adults with degenerative disc disease and degenerative spondylolisthesis. We found about 300 of these references were relevant. And we're redoing this project now, actually. We're in the midst of it, looking at data now from 2003 to 2009. And so data from that many papers, we tried to basically cull the papers and see how many of these were from prospective and randomized trials, how many of these were from case reviews. Obviously, if you have a prospective and blinded trial comparing outcomes, then that gives you a much higher class of evidence than if you have a series of case reviews. And there were not, from 1966 to 2003, any real good prospective and randomized trials comparing treatment of low back pain with surgery versus non-surgery when we first did this kind of a look back. And so there was no treatment standard. What we had were some options, and the options were to consider doing a fusion for patients with low back pain if they failed conservative therapy, and if you could isolate their problem in the lumbar spine to only 1 or 2 levels. If they start having every single disc in their back is a problem and the entire back muscles are collapsed and arthritic from the joints underneath, then you cannot really fix their back pain by doing fusions at more than 2 levels, was the conclusion that we reached. And the reason for that was the more levels of surgery you do, the higher the complication rate. And beyond 2 levels of surgery, what has essentially happened is your complications overtook the benefit that you were getting from degenerative disc disease surgery. So for degenerative disc disease and for spine slippage, if we can isolate to 1 or 2 levels, then we would think about doing a fusion. There are multiple approaches to doing the fusions. Dr. Chow will discuss those, so I won't go into those in much detail. But it is true that if you put bone graft in, as one of the previous people was asking me, how do you fuse the spine? You have to put in bone graft, and the way you do it is you can basically take out the disc, and all this red stuff is bone marrow, and it's held in place by the structural little cage here, and this is called a lumbar interbody fusion, and this is how, with some rods and screws and that bone graft, that you stabilize a slip level like this. And the other way that you can stabilize a slip level is you can also pack bone into the facet joint, but that does not fuse at higher rate as if you put the bone graft into the disc space. So these can help if you do at 1 or 2 levels, but it's not designed to do every level of the lumbar spine. The exception to that is patients with scoliosis who have, as we'll talk about later, more and different problems than just having a degenerative disc space collapse and a slippage. So the question was, is the bone graft just the marrow or is it a hunk of bone? It can be both. So you can use marrow from the pelvis, which has a very high incidence of healing. You can also use a laminectomy bone if you had to unpinch the nerves and you take the bone from back here and mince that up into chunks and pieces. It doesn't have the more marrow you have in the bone, the higher the likelihood of the bone graft healing. There was another question. So the question is, how long do these implants last in the spine? So in the United States, it is our practice that these are lifetime implants. We do not take them out. Now in Europe, some places they do go and do another operation, take them out, but we don't think it's worth it because basically you have to put the patient back under general anesthesia and reopen the skin of the back to go get it, and it hasn't been a problem for us to leave it forever. So when do you do this kind of surgery? If you have 1 or 2 level degenerative spondylolisthesis or slippage of the spine, here's an example. The spine here, nice in-space disc, nice tall disc, nice tall disc, nice tall disc, nice tall disc, no slippage. The spine is beautifully lined up. Here you have a completely collapsed disc, 25% slip, so that's a spondylolisthesis with the degenerative disc space collapse. And this patient failed conservative measures, strengthening the back muscles, strengthening the abdomen muscles, losing weight, and still having pain such that they cannot sit for more than 5 minutes and can't stand, can't walk distances, and start taking narcotics. This is the kind of case where we would consider a lumbar fusion. This is also the kind of case where we would not consider an artificial disc replacement. Why? Because the spine has slipped. The spine has slipped. It indicates that your facet joints are abnormal, and currently there are no FDA-approved facet joint replacements. So the current treatment for this is to fuse the spine by pulling this back into position, putting bone graft in the disc space, and locking it there with screws. And we can do that at 1 or 2 levels only, typically, unless patients have scoliosis or trauma and tumors, which is a completely different story. So the contraindications is more than 2 levels of problem because the complications start to outweigh your benefits. If they have single-level disc disease with leg pain without symptoms of back pain, we do not do a fusion. We just open the nerve hole. If they have severe osteoporosis and the bone biology is poor, it doesn't matter how much bone graft you put in there, it'll never heal. So people who have really bad osteoporosis, I tell them, I'm sorry, I cannot do a fusion for you unless you get that osteoporosis fixed by taking medications and things that people do. So when you do a fusion, which was another question of where do you put the bone graft, this is a demonstration of a posterolateral bone graft. So the bone being packed around the facet joint and instead of being put in the disc space, or this can be done in addition to putting bone in the disc space, and then the rods and screws stabilize. but Dean will be talking more about these topics. The question is, why does bone in the disc space tend to heal better than bone back in the joint? Because most of the loads of the body come through the disc. Most of the bony surface area of the spine is inside the disc space. So if you are someone who's trying to get a fusion, you want to take advantage of the spinal loading and the bony surface area, and this is where you're more likely to get a fusion than a small area back here. There's good vascularity typically here if you take out all the disc and prepare the end plates very well. And if you do an interbody fusion, you can often restore some of the height of the disc space because these discs typically collapse as people age. And as you notice, as people get in their 60s and 70s, if you check your height and compare it to when you're about 30, you've probably lost an inch, maybe 2 inches of height. Why does that happen? Well, you lose that because the cartilage in your knees shrivels up and the discs in your back shrivel up, and so you lose height incrementally from each of those areas. And so in order to, you could restore some of the height by doing an interbody fusion. Dean will talk about more of this kind of business, interbody fusion from the front versus interbody fusion from the back. So the ways that we get into the disc space is sometimes we come through the abdomen. And if we come through the abdomen, we have to work in between the iliac vessels for L5-S1. This would be the L5-S1 space. Or in L4-5, we have to have the vascular surgeons help move the vessels out of the way so we can access this disc space. We do a fair amount of this kind of surgery here at UCSF because we have a very talented vascular surgery team that helps us to access these areas. Of course, some of the complications you can just imagine from coming through the front is injury to the vessels. So in addition to that, sometimes we do the fusions coming from the back so that we don't have to go anywhere near the abdomen. And when we come from the back, we can use an open midline incision, or we can do a minimally invasive off-lateral incision, or some of these other options, which Dr. Chow will talk about. My personal preference is if the problem is at L4, L5, I usually want to come from the back because I don't want to have to move all those vessels over in the front and do all that kind of work with a vascular guy. L5-S1, I typically like to come from the front because trying to get it from the back, the pelvis sometimes overhangs the way we want to do the surgery. And at L5-S1, you really don't have to mobilize the vessels because they split off and get out of your way. So that's usually my personal preference. So this is an example of coming from the front to replace the bottom disc by putting bone in cages here. And there are complications from our series of about 400 in some of these cases. Retrograde ejaculation means that males can have sex, but the sperm does not come out. It goes backwards into the bladder because some of the small nerves in this area can control that problem. You can have a wound infection. You can have failure of bone graft to heal. You can have injury to the surrounding bowels, vessels, the ureter, the bladder, or you can have a hernia. So all those things can happen somewhere in the neighborhood of 10 to 11%. So somewhere in the neighborhood of about 90% of patients do well, but as with everything, there are troubles that can happen. And so whenever we do the surgery, we always talk to the patients about these kinds of troubles. Because of this problem in particular, I don't offer anterior lumbar interbody fusion surgery to patients who are considering to have children. So if they're considering having more children, we don't want to do that kind of operation because if they're rare, even though it's a rare problem, they get that problem, then they have difficulty conceiving. One of the other things that's been published in recent literature is that avoiding the use of the bovie, which is the electrocautery, to cut into the disc space can actually spare all those nerves. So if you do a sharp dissection with a knife rather than using the bovie electrocautery, then the suggestion is that the rate of those problems is much lower. But still, we're talking about can be somewhere in the neighborhood of most published series of 2 to 3% of patients can have that problem. And so if it's someone who wants to have a child, I just don't usually think it's worth the risk, and I'll go posterior. Posterior lumbar fusion exposures. This is a standard way we used to do these operations, a big open exposure with the midline cut in the back. And it may have significant blood loss if the patient is a big person and weighs 200 pounds and has deep 6 or 7 inches of muscle. You can just imagine how spreading all this stuff out, you could bleed, and you may need a transfusion for that. Sometimes you don't, and oftentimes we're quite good here and we don't have to have a transfusion, but it is possible. More recently, minimally invasive operations have been done in this area to try to get the same approach, coming through a tubular retractor and not making a midline cut and spreading the muscle out to the side. By putting the tube in and dilating the muscle, then potentially the blood loss can be less. You get the same result that you do with an open surgery. And there's a suggestion of maybe the blood loss is less and the hospital stay is less when you do that. I like to use personally the tubular retractor, especially in deep patients who are very muscular in their back, or in patients who weigh more than 200 or 250 pounds, because to try to get that exposure there can be quite difficult. And putting in the tube, even though it may be a long depth of the tube, for me, causes a lot less blood loss. It is difficult to access L5-S1 through this. Why? Because the pelvis sits here. And in some patients, the pelvis blocks the trajectory of your tubular retractor. It can block the trajectory of your open retractor and your pedicle screws. So L5-S1 is technically more challenging than to do at L4-5 coming from the back. And that's the view basically you get through the tube here. And so this is one of my patients. The incision's not too big. We do two small ones on each side. If we had opened this midline, we probably would have gone from here to about there. So in 2008, we published our series of comparing the open to the more minimally invasive surgeries. And what we found was that the blood loss was about cut in half, and the length of stay was reduced from 5 days to 3 days, pretty statistically significant in both of those areas. So I think this has some promise, and this is something which has been appearing now for the last 5 years because of the newer technology available for spine surgery, and we didn't really have this 10 years ago. Most people didn't even know that that could be done and weren't trained to do it. There was a meta-analysis by the group at Cornell looking at a series of 23 publications comparing open and minimally invasive surgery, and the complication rates in terms of nerve injury, infection, and things were similar, but there was a trend towards the minimally invasive having a lower rate of complications, specifically because of less blood loss and somewhat of a shorter hospital stay. So we'll move on to my next topic, which is spinal trauma. If you think of the spine, probably the easiest way to think of the bone is if you divide it into 3 columns. Here's the front column, here's the middle column, and here's the back column. If 2 of these 3 are unstable or broken, then you can think of the spine as potentially unstable. And this is probably the most simplistic way of thinking of the spine in terms of stability. And this is Denise classification. But there are many classifications. There's no single one classification that's used. So I think if you divide the kinds of fractures that people get, the most frequent one that I see is a compression fracture. And this is basically the front of the spine is crushed down. And the reason this happens is typically osteoporosis weakens the bone. And then even with stepping off a curb, the front of the spine can kind of collapse on itself. And this can be really quite painful. Often see it in women in the age of 70 plus who have osteoporosis. The other ways that you can get these kinds of fractures are more with trauma, where basically you have bone that's pushed out the front, bones pushed out the back, pushing on the nerve roots, and the worse you get down the scale here, the more surgical you become. A quote-unquote stable burst fracture means the bone in the front and in the middle has been broken, but it's not causing a neurological deficit. An unstable burst fracture is the bone is broken, pushing on the nerve so badly that the patient is having neurological problems, and then these are basically dislocations of the spine where basically you have to put the spine back together, and all of those can cause quite a bit of back pain. But this is the most common one we see, is the compression fracture. And this is one where the 2 treatments have been essentially not surgical. One option is to put the patients in a brace and try to mobilize them in a brace and have more of the brace for about a month, month and a half until this heals over. And the other option is called a vertebroplasty, where sometimes the needle is placed in here and a small amount of bone cement is injected. Both of those procedures have some varying effects of decreasing the pain over time. A suggestion that a cement injection is faster than wearing a brace for a long time, but there's been some studies now where people are not quite sure how much a cement injection helps over the brace. But I do think personally that it does help. A stable burst fracture is a crack all the way through the vertebral body, but without a neurological deficit. And so there might even be a little bit of bone in the canal, but it's not really pressing on the nerve roots enough to cause neurological problems. So if they're neurologically intact with this kind of fracture, and this can happen in young people typically falling off of something, what we do with these folks, we put them in a brace, usually for about 2 months, and most of these typically will heal. The unstable burst fracture, the problem is that the bone is broken and it's pushing severely on the nerves, and they have neurological deficits where they start having weakness or can't control their bowel and bladder. These we have to operate on to unpinch the nerves and to restore the stability of the spine. And the same with the dislocations, where basically you have injury to the front and injury to the back. Those also we would like to operate on, and we don't usually try to even brace any of these. And fracture dislocations for sure, where the spine is twisted around, you can see what's left of the spinal canal is almost nothing, and this is where patients can have really bad neurological deficits, and these we operate on surgically. So the goals of spinal trauma surgery is to unpinch the nerves and create a fusion. So we put all this hardware in, but the hardware by itself is not going to help. What we need to do is surround the hardware with bone graft, which we like to get from the pelvis or from the laminectomy bone. And then we like to recreate the stability of the spine in order to try to get the patients to stand up erect. Which brings me to my last topic, question. So in my personal experience, we usually like to try, if we're going to do a vertebroplasty, we like to do it within the first few weeks after the fracture. Before the bone is really healed. The question is the timing of vertebroplasty and will they get back to normal. And so my personal experience has been once they get the vertebroplasty, usually within about 24 hours, they feel quite a bit better. They're not ever 100% back to normal. No matter how, what we do in someone who's 60, 70 years old who breaks the bone in their back, there's going to be certain maneuvers that they do where they will recreate the pain. But if we can get them ambulatory, walking, doing most of their activities of daily living, we're usually pretty happy about it. And I think the vertebroplasty in my hands has been quite effective to do that. Even with fusion surgery, by the way, same question you could ask is, you know, are you going to get back to 100%? I usually tell patients, you're never going to get back to 100%. No matter what I do, we're not going to get you 16 years old. And so that's just the way it is. And if you have back pain and leg pain, I usually tell them your back pain will probably be 60% better, and your leg pain will probably be 80% better, but we'll never get you 100% pain-free. If you go and you lift something bad and you jerk your back, it's going to hurt again. So scoliosis is my last topic. So basically, if you look at the spine from the side is not straight. It should not be straight. If you look at the spine from the front, as I'm looking at you, if you did an x-ray of me, I don't think I have scoliosis, so you probably would see a straight spine from the front, but if you put somebody to the side, you can see that they'll have a curve in their low back and a curve the opposite direction in their upper back, and this is called a thoracic kyphosis and a lumbar lordosis. And that's normal. And so if you don't have enough curve back here, which happens in patients who start to be 60 and 70 years old because all these discs dehydrate and the spine starts to flatten, then you start seeing people walking forward bent. And we'll look at some of the examples of that. So typically, you have a relationship of the thoracic to the lumbar being two thoracic angles of the curve compared to one lumbar angle of the curve. So the relationship is typically 2 to 1 there. But let's look at some of this from a biomechanical point of view. If your head is here where it says Z, and your neck and your shoulders are here, and you biomechanically want to look at the spine, you drop a plumb line from there. If that plumb line lands over your tailbone, then your spine is in good balance, and that's called sagittal balance, which we're finding to be a very important topic nowadays. And in fact, there's some leeway to it. If you drop your plumb line from your head in the top of your neck, and it lands anywhere within 2.5 centimeters of the tailbone, then patients usually don't have symptoms and can stand up straight and are usually quite happy. Now the problem is what happens when you have imbalance. And imbalance happens as we age because the lumbar discs degenerate, they lose their height, the spine starts to lose its lordotic curvature, and the spine starts to tilt forward. And as you tilt forward, then gravity keeps pulling you forward. And the more gravity pulls you forward, the less you stand up straight, the more back pain you have. So this is an x-ray of a normal 50-year-old patient. This is an x-ray of a 70-year-old patient who came to my clinic complaining of a lot of low back pain. And you can see the plumb line here, the weight of the shoulders, the head, the trunk, all lines up over the tailbone within 2.5 centimeters of tailbone. This person does not have back pain. This person has tremendous back pain because as she tries to stand up straight, she cannot stand up straight. She has insufficient curvature of her lumbar, excessive curvature of her thoracic. Her body weight and the weight of her shoulders is several centimeters forward of her tailbone. So her back muscles are trying to pull this back, and they're losing because they are not stronger than the bone and the structural rigidity of her bone. So this person is going to have a lot of back pain, and the more she leans forward over time, she'll keep going forward because gravity tends to pull you more forward. The other thing that we're learning too is that there's a relationship between the hip, the tailbone, and how much curvature you should have in your back. And I don't need to go through every single one bit of this, of the pelvic incidence, but we've figured out lately that people are born with a certain angulation between their tailbone and their hip that does not change. And if you don't have within 10 degrees the amount of lumbar lordosis to be within 10 degrees of this relationship that you're built with from your tailbone to your pelvis, you start getting back pain and you start leaning forward. So this pelvic incidence is a fixed parameter. You can't change it. And if you don't have enough curvature in your back to overcome it, you start leaning forward and getting back pain. A normal pelvic incidence is around 50 degrees, which means that the average patient needs about 50 degrees of lordosis in their lumbar spine, or at least 40 degrees. You've got to be within 10 degrees of the pelvic incidence, so at least 40 degrees in order to stand up straight. So this parameter here, the pelvic tilt, you can change. So there is some compensation ability. So this is a person who has an alteration in their pelvic tilt to try to stand up straight. But that really requires you to rotate your hips. And if you start having hip joint arthritis, you'll lose that ability. So all examples of a pelvic incidence, which is this measurement with a different pelvic tilt in each of these different kinds of compensation maneuvers. So not a lot of lumbar lordosis, the patient standing up really forward, trying to strengthen and use their hips to rotate back and hips to rotate back and using their core muscles. Some of them can get up straight, but you've got to have, over time, at least 10 degrees of your pelvic incidence within your lumbar lordosis. And this is how you measure lumbar lordosis. So you got to be within 10 degrees of this here in order to stand up straight and not have back pain. In the young, you can compensate. You can compensate by tilting your pelvis, by bending your knees when you walk, by using your extensor muscles. But when you start to, as you start to age into your 60s and 70s, you get back muscle fatigue because you can only pull for so long before your discs have degenerated to the extent where you can't pull them back anymore. And then your knees wear out, and this patients will start getting knee and hip replacements because if they walk around with their knees bent all the time, trying to get their pelvis to rotate over, then over time their knees wear out. So this is I'm going to stop with this case example, but this is a 50-year-old man who had a lumbar fusion, was sent to my clinic because he still had back pain. And when we look at his x-rays, he's got a nice solid bridging bone here, so his fusion did not fail. His hardware was in good position. And we look at him from the side, and he had a L4, L5 fusion. They took the hardware out because that was solid, and he broke down the next level, so they extended his fusion, but his bone graft is solid, and his lordosis does not look bad here. And his doctors couldn't figure out why he was having problems, so they did a myelogram where they put in some dye and they looked for any nerve pinching in here. There's no nerve pinching. He's got a nice, big, wide open spinal canal. So it was unclear why the patient was hurting. So the patient came to see me in clinic, so I got a full-length x-ray to see what is his sagittal balance. And what we see is he does have some lumbar curve, but he has such a big pelvic incidence, he has nowhere near enough lumbar curve. And gravity pulling him forward because he's been walking, leaning forward. And now you can't even see his head on the same x-ray as his tailbone. And so he's about 15 centimeters forward of his tailbone. And this is why he's hurting, because his back muscles aren't strong enough to pull him back. And as gravity has kept pulling him forward, he's just kept going forward. So if we want to measure lumbar lordosis, we would measure it by drawing a line here and a line there. And this is probably lumbar lordosis somewhere in the neighborhood of 20 to 30 degrees. If we look at his pelvic incidence, he's got about 50, 60 degrees. 20 to 30 is nowhere near 50 to 60, and so he doesn't have enough. He's leaning forward. He keeps leaning forward. And so we had to do a big surgery on him to give him the curvature back into his spine. And now he stands up straight. And now when he stands, you can drop a plumb line and it lands over his tailbone. So the question was it worth it for him to have every single one of his spine instrumented? And so what I told you is if we do it for lumbar degenerative disc disease, we would never do this. But what he had is a spinal imbalance problem. And his spinal imbalance problem is because his shoulders and his torso don't line up over his tailbone. So he can't stand up straight. He stands up leaning on his walker. So when you can't sit and you can't stand and you're taking a boatload of narcotics and you're at the end of your rope and you've tried a couple of small lumbar surgeries, that's when you're at the very end of your rope and I try something big. But I won't do this to the average 50-year-old who comes to my clinic, if that's the question. So the question is, 20 years later, what happens to him? Well, you know, I've instrumented him from T3 all the way to the bottom, so he can't have any adjacent segment problem here. He's fused all the way down to the bottom. Could he have adjacent segment problem up here? He could if he gets osteoporosis and he loses his ideas of getting good posture and he starts to slump over here and he doesn't pay attention to his posture. He can break down above his fusion. That's called adjacent segment degeneration, and it certainly could happen to him. And so one of the talks that we had after we did this surgery is how he needs to keep this musculature here strong and keep his posture in good shape. So the hardware that we used to do this particular kind of operation did not exist 20. She was asking 20 to 30 years ago, people who had this problem, what happens to them. 20 to 30 years ago, we had a much more primitive instrumentation system called Harrington rods. And those were not used for patients in their 50s. Primarily, they were used to correct scoliosis in teenagers. And so teenagers who had those rods put in 20, 30 years ago, typically the rod would stop here and it would stop here, and the area below and the area above sometimes would break down if they did not have good posture because it wore out. No, usually we connect. Domino. The question is, do we take the old rod out? We usually connect. I have a question in the back there. So a question was arthritis and how do we prevent arthritis? I think the single most important thing that's in everyone's control to prevent arthritic change in their spine is to not use tobacco. Tobacco accelerates arthritic change. The other thing that is a problem with arthritic change is repetitive bouncing maneuvers, things like skiing, running on pavement. Those all wear and tear on your knees, your hips, and your low back. And also keeping yourself in good shape with good posture and to avoid having excess weight on your frame will also help you to avoid having arthritis, which typically settles in your low back because all your body weight sits here. And also, those are the same maneuvers to keep your knees and your hips out of trouble and avoid joint replacements. Question here. So if we look at this person, he is craning his neck maximally backwards. The question is if you have kyphosis, and this is called kyphosis, where you have too much leaning forward. If you have this kyphosis and you want to look forward, you have to crank your neck all the way back just to look to see where you're walking. So if you do that for a period of time, you wear out your cervicothoracic junction. You can have neck pain from it. Rotational, the question is, can scoliosis twist? And that's rotational scoliosis. Yeah, so and also similar idea, we put screws in and we twist it back. We have to cut the bone out to make wedges out of the bone and then put the screws in and twist it back and lock it there. So the question is, some young people with muscular dystrophy get spinal fusions, and is this the kind of spinal fusion they would get? Yes, it's very similar to this. What happens with muscular dystrophy is that the spine will rotate around and get a very bad rotational scoliosis and also tip forward, causing a kyphosis. And then we have to often, some of that can be so bent over that your internal organs may not work correctly. Your lungs may not be able to expand. Your bowels may not function normally because you're so bent over. And to straighten those patients out in this fashion is typically what happens, and those patients have very poor musculature, so they get a lot of problems. Even with surgery, they tend to have complications. Yeah, so the problem with radiation is it kills the muscle and it destroys some of the bone underneath too. And so you can have patients who basically with the muscle atrophic, they start to lean forward and they can have problems with radiation after they get radiation to the spine. Typically those effects take a few months, sometimes a year or more to come into effect. Most patients who have radiation at the 7-week marker beyond radiation, I typically don't see those problems. It depends sometimes on the dose and what part of the spine it goes to. A question in the back row. So we have a multidisciplinary team where we use physiatrists who are rehab docs, we have pain docs, and we have radiologists, and we have neurologists, and we have surgeons. So basically, when they come with back pain, we will start with the conservative therapy with the rehab docs and with PT, and then we'll move on to injections with the pain docs and radiologists. And if we can't figure out why they're having pain, we'll get a neurology evaluation, get a nerve test, and then only if they've failed everything else and we can isolate their problem, then we'll do surgery. Question here in the front. Well, how can you keep your disc juicy? So the way you keep your disc juicy is to avoid smoking, avoid repetitive bouncing activities like running or snow skiing on moguls, and to have good posture and to keep the weight off. Yeah, psoas muscle can spasm. You can, just like any other muscle, you can pull that one too. The psoas muscle often has inputs, which can also cause your hip flexors to work and not work, and that comes from L1, L2. So you can have muscle spasm in your psoas and your hip flexors if you have herniated discs at that level. Yeah, there are some patients, the question is iliolumbar ligaments. There are some patients who have so much contraction in their hip that that's what prevents them from standing up straight. And so we will do what's called a Patrick's test of the hip. We'll rotate the hip around. And if the problem is in the ligaments and in the hip joint moving in the first place, and that's what's keeping them from standing up straight, then we'll focus on the hip as a pathological entity. Okay, so I'll give this over now to Dr. Chow.
All right, well, my name is Dr. Dean Chow. So now that we've talked about the non-operative causes of back pain, we're going to go and talk about surgery. So when does surgery work? Let's look at the numbers first for back pain. So in terms of back pain, 80% of Americans have back pain at some point in their lives. That's 240 million people. That's quite a number of people. And for 95% of these people, surgery is not appropriate and will not make them better. If you look at the numbers, the second most common symptom-related visit to a physician is back pain after the common cold. More than half of the patients state that it disrupts their activity, and it can happen at any age. If you think about how much this specifically affects America, opioid use, Americans constitute 4.6% of the world's population, yet we use 80% of the global supply of opioids. It's a pretty amazing number. And if you look at the costs of back pain to society, in the United States, direct and indirect costs of low back pain are estimated to be about $90 billion per year. And it's estimated that 5% of back pain patients, so 5% of this group, accounts for 75% of the costs that we incur as a society. So as Dr. Mumeneni was saying, why is it so hard to treat? Well, number one is you can't locate the source. The million-dollar question is, well, where is the pain coming from? Number two is that the spine continues to degenerate despite therapy. So just because you do something to the spine, you say, well, my spine should be fixed now, shouldn't it? Well, in reality, it isn't. It's only treated. It's just like if you go to the dentist, you go get your cavity filled. It doesn't mean you never have to brush your teeth again. You never have to floss again. It doesn't mean your teeth are perfect for the rest of your life. The same thing that happens to your teeth happens to your spine. Some of these treatments are temporary, and some surgeries are done for the wrong reason. The three most common healthcare professionals sought by patients with back pain are chiropractors, massage therapists, physical therapists. They're not medical doctors. And the other thing that's also interesting is that even though 5% of the patients actually need surgery, 50% of patients believe that surgery is the only cure. Now, well, where does surgery do well? Now, in the old days, it used to be, well, I'm a doctor, I've been doing this for 30 years, you got to listen to me because I know what I'm saying. As many of you know, that's no longer the case. Now it's, well, what does the evidence show? What are people actually doing if you took 200 patients and randomized 100 to this group, 100 to that group? How do these patients actually do? It's no longer the days of, I'm the senior doctor and I know what I'm doing. So you got to think about, where does surgery do well? So we know, based upon data, patients do well with nerve compression, right? So if you have stenosis, lumbar stenosis, if you have a disc herniation that doesn't get better with conservative treatment, patients do well. We know that, and there's data to show that patients do well. Instability, so if your spine moves abnormally, patients do well. And that Dr. Mumeneni mentioned also. If you have an isthmic spondylolisthesis, meaning you've got a fracture in your back and your spine is moving pathologically, you're going to do better with surgery. Deformity, as Dr. Mumeneni also talked about, adult scoliosis, spondylolisthesis. If you're slipping and sliding and your back is no longer holding you up, you're going to do well with surgery. And the reason is that your back is a structural organ. It's just like the Leaning Tower of Pisa, right? So if the tower is leaning and you want to try to fix it, you can, and if you've got a person trapped at the bottom and you want to free that person, you can dig more dirt around and free that person up. But what's going to happen to the tower? It's just going to keep leaning over again. And if you say, well, why do you put all those screws in that patient? Well, if you put one screw in the Leaning Tower of Pisa and try to pull it back, it's just going to rip right out. You have to do what Dr. Mumeneni showed with a lot of screws. There's no way that you're going to be able to fix that person with one little screw and some minimal type of procedure. If you need to pull the Leaning Tower of Pisa back, you have to pull it back. We know that also worrisome pathologies, which we're not going to really focus on here, But tumors, if you have a big spine tumor, infection, it's a whole nother story. But we know that in many of those cases, there are surgical options. So again, where is the pain coming from? Is it coming from the muscle, the disc, the facet, the nerve? Is it psychogenic? Right? So is it coming from our head? Okay? And think about the history. Did you play any aggressive sports when you were younger? Basketball, football, gymnastics? Classically, many of these patients may or may not have a fracture, and they've got accelerated arthritis. Okay, and that's something that a lot of patients don't realize. They think, well, if I'm going to be a very aggressive player, I'm going to be very, very healthy. But a lot of times you'll see these patients, they have pretty aggressive arthritis much earlier for their age than other patients. Also think about whether or not you've had a fall. If you've got osteoporosis and you've got a fall, you get a compression fracture I was talked about earlier. If you've got a history of cancer, if you've got pathologic fracture. One thing I'm going to talk about with osteoporosis is that, you may or not know, but in osteoporosis, we only lose bone. Our maximal bone density is when we're teenagers. So everyone says, oh, I got to increase my bone density. You can't. Once you're past about the age of 19, we all lose bone. And so if you have young nieces, nephews, grandchildren, or children, you got to tell them that they need to maximize their calcium and maximize their bone density while they're teenagers. So ever since we were teenagers, we all lose bone. And you can't just give calcium, you have to give vitamin D, right? You need vitamin D to absorb the calcium. And again, there's only one drug that really grows bone, quote unquote, and that's Forteo. Everything else just sort of slows the process down.
What was that again?
Forteo. So the million-dollar question is, where's the pain coming from? Let's go through some of the diagnostic studies. So plain x-rays are useful. So the x-ray is very useful, which is different from an MRI because we're standing up with an x-ray. The MRI, you're laying down. So it's really useful to look at an x-ray. CAT scan. Now what's so good about a CAT scan? A CAT scan is good because it looks at your bony anatomy. An MRI, you need an MRI if you have any pain in your legs or pain in your buttock, because an MRI is really good at looking at soft tissue. It's looking to see if you've got any type of nerve compression. It's also very sensitive. It will basically pick up all these things: stenosis, herniations, disc bulge, hypertrophy of your facets, foraminal stenosis, bony changes, arachnoiditis, which is inflammation of the covering of your nerves or tethered cord. And the myelogram, this is something that was used in the old days, but now that MRI has really come about, people really don't use this, but it can be useful. And then we'll talk about injections. How do steroid injections work? So if anybody has pain shooting down their leg, there's two components of that pain, right? So the first one is a mechanical pain. So something is pinching the nerve. So short of alleviating that pinch, there's an inflammatory component, right? So if you take your finger and you slam a car door on it, you open the door, it's still hurting because it's inflamed. Even though you've removed the mechanical component, your finger still hurts. So what the injections do is they treat the inflammatory component, but they don't treat the mechanical component. So same with steroids, non-steroidal anti-inflammatories, non-steroidal anti-inflammatory medication. So again, as Dr. Mumine talked about, epidural steroid injections, relatively low risk, maybe temporary. Discography, very controversial, right? So this is a very controversial topic. I'll get into this a little bit later, but this is something that's very controversial. And what it means is if you're looking for a cause of your back pain, what the discography does, it's going fishing and looking for this cause. There's no real long-term data to support or to refute discography. So when should the patient see the surgeon? So if you have a neurologic deficit, foot drop, you should see the surgeon. If you have weakness in your legs, if you fail conservative treatment for 6 months, including physical therapy, injections, and pills, or if you've got a structural lesion, if someone's given you the diagnosis of scoliosis, stenosis, spondylolisthesis, bony destruction from either tumor or infection, a disc herniation, what about non-surgical causes of back pain? So if you don't have a structural abnormality, so if you don't have scoliosis or stenosis or spondylolisthesis, The other thing is if you can stand upright and erect. If you say, well, I can't stand up straight because I'm leaning forward all the time, that's a structural problem. And there's a good reason you're having back pain. But if you can stand up straight and you can balance your head over your pelvis over your feet, you don't have a structural cause of your back pain. And also if you have age-appropriate degenerative changes on your MRI. So the other thing that's very controversial is discogenic pain. And this is something I'll get into a little bit more also. But they'll say, oh, doctor, I've got this disc pain. I've got degenerative disc disease. I've got 4 bulging discs. You got to fix them. 4 bulging discs. I've got an unhealthy disc. Look at this report. I've got unhealthy discs. Well, what are all these changes? They're just normal aging. They're normal aging. It's like saying, oh, doctor, I've got gray hairs and wrinkles. You need to fix me. I need surgery. I really need to get operated on. It's the same thing. Everything that happens in our body is the same thing that's happening in our spine. So if you look at whether or not these degenerative changes actually are the cause of back pain, you'll see that there's other reasons why people have. So the New England Journal of Medicine did this way long ago, 1994. They took 100 people, or whatever it was, 90-something people off the street who had no back pain, just randomly brought them over, stuck them in an MRI machine, and MRI'd them. And 64% of them had an abnormal MRI. So they have absolutely no back pain. They've got bulging discs, collapsed discs, degenerative discs, but they have absolutely 0 back pain. What does the data say? Well, we just did this systematic review, and this came out last month in Spine. And if anybody's interested, it's a focus issue on low back pain. And it's a very, very interesting issue. We basically devoted 15 articles to low back pain. And the one I was an author on was exactly this topic, which is degenerative changes. And what we looked at was degenerative MRI changes in patients with chronic low back pain. And so what we found and what we did was we looked at all the world's literature, Swedish back pain studies, everything in Europe, everything in Asia, from Hong Kong, from America. And what we found was there may be an association between these degenerative changes and low back pain. Okay, so there may be an association. But there's insufficient use to say you should routinely use MRI for chronic back pain. There's just not enough evidence to say. And why is that? Well, because if you get an MRI for someone with back pain, is it really going to change the treatment? Right? So if you say I've got back pain, I've got chronic low back pain, you get an MRI, it shows I've got degenerative disc, collapsed disc, facet arthropathy, all these things. This radiology list, this huge laundry list of things. And so what are you going to do? You can do the same thing you did before the MRI, right? You're still going to get physical therapy. You're going to take some pain pills. You may get an injection. You may do cognitive behavioral therapy. You're not going to change your management. But there's a morbidity of getting the MRI. And this is something that we describe in the article. And this has been described elsewhere. So what happens when the patient gets the MRI, they're labeled. So they say, oh, I've got this, I got degenerative changes, so I'm labeled now. These are the things that are wrong with me. And the patient is convinced these are the causes of their back pain. They're convinced. They say, I've got these bulging discs. This is causing my pain. When in reality, most of the times, they're just changes that happen to us as we age, and they may not be related to anything. So what do? They go to subspecialist, then another subspecialist, potentially seeking an unnecessary surgery. They get their back fused, and they get another back fusion, then another fusion. You hear about these patients who have 10, 15 surgeries. So if you have degenerative changes and you operate on those, you have to be very, very careful, because there's no convincing evidence that it's actually going to help you. And then when the patient goes to their family doctor, they say, oh, I've got this back pain. The family doctor, many times rightfully so, will say, well, you don't need an MRI. And they say, well, this family doctor is no good. He's not giving me, or she's not giving me the standard of care. I'm not getting high quality medical care. They just send me to PT and send me on my way and give me some pills. I need an MRI. And so these are things that when you get the MRI, they can cause pretty significant morbidity to the patient. So these are also things to think about with regards to the MRI. Now, what about surgery for degenerative disc disease, right? So again, Sohail Mirza, who was at the University of Washington, did a very nice systematic review of doing surgery for degenerative problems. And they found that surgery may be more efficacious than unstructured non-surgical care for chronic back pain, but may not be more efficacious than structured cognitive behavior therapy. What does that mean? That means, so they looked at all the data, and again, they looked at the good data, not bad data, not like I've been a doctor for 30 years, here's my patients, they all do well. This is prospective randomized trials where they looked at patients and they said, okay, this is what the problem is. These are the patients who have back pain, and these are the patients that I'm going to randomize to surgery, and these are the patients I'm going to randomize to medicine therapy or non-surgical therapy. And then let's look at the two groups. And so if you were a doctor and you said, well, here's a prescription for PT, see you later, you don't need any surgery, those patients actually didn't do as well as if you took a patient and said, well, I'm going to send you to Mr. X here, and this person's going to teach you physical therapy, they're going to help you deal with your pain, they're going to send you to a cognitive behavioral psychologist, they're going to have a structure. Every day you're going to do X, Y, and Z to help your back pain. Those patients who had a structured cognitive behavioral therapy did just as well as the patients who had a big lumbar fusion. Okay, so that is one thing that's very, very important. And a lot of times, it's not so much the pain that changes, but how you deal with the pain. So I'll give you an example. There's one gentleman who was a corporate lawyer, very high functioning, a 35-year-old man who couldn't work as a corporate attorney because he had horrible back pain. And we did all these things, we treated him for about 2 years, and finally we sent him to a cognitive behavioral therapist. And every time I'd see him in the office, he'd be pacing, uncomfortable and pacing. And one day I went in and he was just sitting there reading his book comfortably. And I said, well, what happened? He says, oh, I'm feeling well. I was like, how's your pain? He's like, it's still there. And I said, what do you mean? He says, well, I went to see the psychologist and it's still there, but I now know how to deal with it. So instead of having the pain at the forefront of his mind, it was off to the side. It wasn't occupying all of his daily life. And so that is something to think about, cognitive behavioral therapy. What else did we look at? We looked at surgery for chronic MRI changes. So you got a bulging disc, I'm going to do surgery on you, let's see what happens. When we looked at that, there was absolutely no data comparing whether or not surgery helped those patients. Bulging disc, collapsed disc, facet arthropathy, hypertrophy, et cetera, et cetera. So these degenerative changes, operating on them, it's unknown whether or not they actually do anything for you. So it's really, really important to keep that in mind. If this is something that you or your loved one has, or anybody you may know, and say, you know, I think I need surgery, well, maybe you don't. Maybe surgery is not an option. Okay, so again, 95% of patients with back pain don't need surgery. Okay, so even though 50% of them really think that it does. When does surgery help people? So again, these are the treatable causes. We know patients do well. Lumbar stenosis, disc herniation, spondylolisthesis, or the slippage of your vertebrae. Positive sagittal balance, pitch forward, right? If you can't stand up straight, you're uncomfortable. Coronal balance, being tilted off to the side. If you're walking around like this, it's very uncomfortable. You're not going to be able to stand up straight. And then adult scoliosis. So again, lumbar stenosis, classic is that I feel much better when I'm leaning on the shopping cart. I can walk about a few blocks, I sit down, I feel great, then I can do it again. But if I stand or walk for too long, I have pain either in the buttocks or down the legs. These patients have classic lumbar stenosis, and it happens to a lot of patients. We know that these patients do better with surgery. We know that for a fact, that they do better with surgery compared to medicine. If you look at this, and this is a very, very large study called the SPORT trial. Many of you may know or may not know about this, but it's a very, very large study, prospective, randomized, NIH, multi-center, multi-million-dollar trial that looked at patients with stenosis, and there's another one that also looked at spondylolisthesis. They compared patients with these problems, surgery versus no surgery, and if you had lumbar stenosis, your quality of life was better with surgery. Okay, so if you have lumbar stenosis and it's debilitating, you're going to do better with an operation. Lumbar disc herniation. So if you've got a disc herniation, it's one of the most common problems. As long as you don't have a neurologic deficit, foot drop, weakness, inability to move your leg, you really don't need emergent surgery. And then also keep in mind, some people may say, well, I'm weak, and it may actually be pain. but you can't exert full strength because it's so painful. And again, if you lose your bowel and bladder, that is an emergency, because if you lose bowel and bladder function, it's permanent, right? So you emergently have to do surgery. So again, as Dr. Mumine talked about, spondylolisthesis, so slippage. So spondylo just means vertebral segment. Listhesis means translation, so you slipped forward. When you slip forward, there are two rings, basically, and as the rings slide, they crush the nerves in between. So those patients have a lot of pain in both their buttocks and it may be back pain. And again, if you've got a fracture, we know that if you have a fracture in your back that's causing this spondylolisthesis, those patients do better with surgery than if you don't have a fracture. Okay, so if you have a fracture and you have a lot of back pain, you'll probably do, and you really feel that pain is bothering you, you'll probably do better with an operation. With regards to spondylolisthesis, again, same thing. Conservative treatment is the first step. Epidural injections may work, but bilateral selective nerve root blocks may also help. And as long as you don't have any nerve deficits or bowel and bladder problems, you can treat this as long as you want conservatively. I have had patients who treat this for 20 years and never have an operation. What makes people choose surgery? It depends upon their quality of life. When quality of life is unacceptable to you, so if you're in a position where you go from your living room to your kitchen to the dining room and you watch TV and you're pretty happy with that and that's about all you can do, then your quality of life is not severely hampered. But if you're much more active, you need to walk 5 miles a day, you need to play with your kids or grandkids, and you need to do things beyond those things, then your quality of life may be unacceptable. So each person has a different level of acceptability of their quality of life. Now, adult scoliosis, again, this is such an important topic, and I think it's worth mentioning twice because it really is affecting so many people. And they did a survey that is about 60 to 70% of people, not patients, people over the age of 65 have adult scoliosis. So it's a real problem, especially as we're living longer and we're living with a much more active lifestyle and a much higher quality of life. So this is really going to affect a lot of people. Now, again, every time when you saw those screws and rods, you said, oh my God, why would you do that to a human being? Well, it depends on the quality of life. If your quality of life is absolutely miserable, you may choose to have one of those operations. So again, if you're never going to go back to 100%, but you may get better than where you are. The number one reason that people chose that operation is because of disability. That means they were disabled and their quality of life was so impaired that they couldn't go on without that operation. So you have to think about, you see those surgeries and you say, well, that's pretty extreme. Well, you got to be in a pretty extreme state to actually choose those operations. Okay, let me show you another example. Case example, 64-year-old female. She basically had back pain. She had known scoliosis for 20 years. Worsening over the 8 to 9 years, had multiple consults, had multiple conservative measures, 55-degree curve. You can see her curvature right here. It's pretty significant. It's basically if you had a tree and the tree were nice and straight, it bears the weight of the tree, no problem. But when it's bent off like this, it's going to hurt to stand up because it wants to buckle. And it's the same thing that's happening. The more severe that curve gets, the more disabled this lady became. So we basically did screws and rods on her, and we only fused her curve here. We didn't go all the way up there because we didn't need to, but basically what we did was we braced the entire part of her spine that was no longer holding up her torso anymore. And in an adult, you don't want to get this perfectly straight. There's no need to get this perfectly straight as you would in an adolescent. But as long as you get this part braced and supported, that's the most important thing. And she did very, very well after many years. And again, another example, 70-year-old gentleman, engineer, had a lumbar fusion, L1 to L5 at an outside hospital. He says, now I'm crippled. He can only sit, incredible pain. So he came in to me like this. Literally, he came in walking like he was bowing. And this is how he stood. This is as erect as he could stand. So you see the previous surgeon did a very nice job. He did a nice lordosis. Right? So we talked about lordosis earlier, meaning curvature in his low back. Curvature was real nice. Everything looked great. The screws were perfect, had a beautiful fusion. Everything was fine. But he developed proximal junctional kyphosis, which means that above his fusion, he kyphosed or fell forward. And this is an example of the spine just continues to degenerate. It's just going to do this regardless of what you do. And you can see he's off balance here, and this is what we did to him, same sort of thing. Basically, the only way to pull him back up was to fuse him up to the top. Now, does this really matter? Is this all just, you know, I'm Dr. Chow saying this matters? Well, does it really matter? Well, if you look at the impact of positive sagittal balance in adult spinal deformity, meaning the more forward tipped you were, the more unhappy you were, right? And say, looked at hundreds of patients to see what their quality of life is. The more forward tipped you were, the more unhappy you were. And if you looked at the kyphosis, the forward kyphosis, so if you had high thoracic kyphosis, meaning if you were tipped up at the top, it wasn't so bad. But if you were tipped at the bottom, your whole body is tilted forward. It's just like the Leaning Tower of Pisa. If you tip the whole base, the whole tower falls forward. So you can see at lumbar, which is the bottom of our spines, it was much, much more disabling. ODI stands for disability. So the higher your score, the more disabled you are. And again, positive sagittal balance, decrease in quality of life, increase in disability.
What actually is sagittal balance?
Sagittal balance is how well our head is balanced over our pelvis, over our feet. Because as human beings, you have to stand on 2 feet. And if you stand like this, it's very uncomfortable. It's like if you had a building that was about to tip over and you constantly had cables in the back trying to hold the building up, which is the analogy to our back muscles. They're not designed to hold our torso up in this position, and it causes a lot of pain. There's so much energy that's expended by these muscles to hold our torsos back that it's very painful. Same thing if you're tilted off to the side. They found that if you're tilted off to one side, either right or left, it was a problem. So again, to answer your question, basically you need to balance your head over your pelvis, over your feet. If you can do that, then the chances of you having back pain from this problem are much, much lower. And we know that if we can balance a patient with their head over their pelvis, over their feet, they're going to be happier. The only way to do that is with all those screws and rods. So if you can't balance yourself and you're disabled, then that may be the only thing. And I'll tell you, here's an example. She's only 38 years old. She's 38, and this is what she came to me with, right? So she had a little bit of curve here. You can see that's probably from her adolescent years. But you can see, where's her head? Her head is way over here, and here's her pelvis back here. Her head is forward of her feet, and she's miserable, right? She can't even work. And take a look at what happened to her. 2004, 2007, 2009. Here she is, 2004. She's pretty well balanced, and she went to a surgeon, an outside surgeon, who's a very respected surgeon, and he fused her back. And what did he do to the patient? Look at where her head is now. It's forward, right? So he said, well, you've got pain. You didn't have enough fusion. Let's fuse you more. So he fused her some more, right? So she's even more forward, right? And that's why this is really important to understand. And in the old days, people probably didn't know this. Now, I know people didn't know this. People didn't know that this was the problem. They called them failed back syndrome, or there's nothing we can do for you. And so we know that if you're tipped forward, surgery is going to help you if you need to get pulled back. Okay, so we know that patients are happier with their head over their pelvis, over their feet, and this woman is miserable. So we basically did that, and that's basically what we did. So we basically pulled her pelvis back. We didn't fuse any more of her back at all. We kept the same levels of fusion, but all we did was, to do this, you have to basically cut the spine and then pull it back so she can stand up straight again. And that's all we did. And she's much, much happier. And she's actually now 2.5 years after the surgery, and she's much, much happier because now she can stand with her head over her pelvis, over her feet. Okay, so the basic principles are really, really important. So how to approach back pain. So again, really define if it's treatable or not, right? So you really put the classification. Is this a treatable cause or not treatable surgically? And if it's not a surgically fixable cause, then most back pain, all you can do is just treat it. That's it. You can't cure it. You can't fix it. You can't get rid of it. You can just treat it. And what's the best treatment? Well, nobody really knows because every person is different. So what may work for one person may not work for the other. So it's really trial and error. If it's treatable, determine if it's nerve origin, bone or muscle, or structural origin. Is it disc herniation? Is it stenosis? Is it scoliosis? And then you also want to exhaust all conservative measures before considering surgery. And then if you're considering a fusion, make sure strict surgical criteria are met, either deformity or instability, spondylolisthesis. Non-surgical causes, so if not treatable with conventional therapy, consider cognitive therapy. I can't emphasize this enough. Cognitive behavioral therapy, a psychologist. See a psychologist. You don't have to say, oh, I'm crazy. Just see a psychologist. See if they can help you deal with the pain. Pain management, again, drugs, injections, other modalities of trying to treat the pain. It may or may not work. Some people it works great. Think about alternative treatments, chiropractic, acupuncture, yoga, Pilates, weight loss, core strengthening. You know, some people swear by a chiropractor. Some people think it absolutely does nothing. It makes it worse. So every person has a different thing that will work for them. Some people, acupuncture does absolutely nothing, and some people, acupuncture, it's the only thing that works for them. And again, don't try to seek a surgical solution for something that surgery will not fix. Okay? So in conclusion, as a patient, get all the information, make an informed decision. Quality of life is the ultimate decision factor in your decision. Always remember that the spine, just like the rest of our bodies, will continue to degenerate no matter how successful the surgery. Most back pain cannot be cured. Stenosis, disc herniation, spondylolisthesis, scoliosis do well, but degenerative changes do not do well with surgery. Thank you. A question in the back? That's a great question. The question is, if you have scoliosis as a child or an adolescent and it gets worse as an adulthood, and those patients can be very, very disabled. So there's basically 3 classes of scoliosis. One is what you mentioned, so you had scoliosis as a kid and then it gets worse. 2 is de novo, starts brand new when you're 50 to 70 years old. And number 3 is from some type of metabolic disorder, such as osteoporosis, or one of your legs is longer than the other. So if you have an adolescent scoliosis that is morphed into adult scoliosis, those patients do just as well with surgery, depending on how disabled they are, depending on how forward pitched they are, and depending on whether or not their curve is progressing. The question is, what procedure is done to see whether a nerve has lost its function? Usually something called an EMG, or a nerve conduction test, and that a neurologist does, or a physiatrist. It's basically where they go in and measure how much nerve damage is actually present. Yes, the question is, what is Forteo? Forteo is a parathyroid hormone analog. Basically, parathyroid hormone helps you put calcium into your bone, and basically it's an analog that helps put calcium back into your bone.
Can anyone take it?
Yes, you got to see your doctor and see whether you're a candidate, though. So the question is the sciatic nerve versus the foot drop nerve, are they the same nerve?
Exactly.
They usually are the same nerve. So keep in mind, sciatica is not a medical term, right? Sciatica is a lay term that's like rheumatism, right? So rheumatism isn't a real diagnosis, right? So it's an old-fashioned term for what we call radiculopathy or nerve pain. So sciatica is not really a medical term, so just so you know that. Yeah. So the question is, what is nerve damage? So basically, nerve damage is simply the nerve doesn't function anymore, or it functions abnormally. And so from terms of numbness, it depends on what the cause is. There are some causes that are reversible, there are some that are irreversible, and some of it, there's no good treatment for some of them. Some of them, treatment works really well. So the diagnoses are so varied, and you know, you'd have to go into specifics about what's causing it. So the question is, how long, how much does weight loss play a factor? I think weight loss plays a factor. I don't think it's as critical as a lot of people think, unless you've got positive sagittal balance, meaning the weight is pulling your weight forward. I think as long as you're within a reasonable amount of body weight. But I've got patients who are thin as gymnasts who have horrible back pain, and I've got couch potatoes who have no back pain. So it's not a one-to-one, but I think it obviously helps, but I don't think it's a one-to-one. Okay, all right, well, thanks for coming, everybody. Yeah.